Thank you so much, Dr. Nguyen, for that. It I took so many notes listening to you, and thank you for the history and the recap. And I'm watching the chat on my second computer, and the people in the audience really were able to resonate with so much that you said. And I loved how you ended that, talking about the hope, right? And looking forward. And I'll introduce myself. My name is Ashley Freeman. I'm the manager of stakeholder outreach and engagement. And I'm about to present to you a panel of people who represent everything that Dr. Nguyen said when he talks about that hope and he talks about the new approach of not only learning with, but also from the communities that we're serving. I have three special people here today that signify that. So I have Miss Sharon Rivera Sanchez, Dr. George Trung, and also Nurse Tamron Collins. And they are three people that we met when we did our workshops this year from Virginia. We have California, and we also have Mississippi. And so before we dive into the prepared questions for the panel, we have to talk about what Dr. Nguyen just talked about, really ending on that high note about the hope and the new approach to learning. And I think you, Dr. Trung, you signify that for me. You are a second year resident at UCLA. You're young. You have this understanding of the importance of not just seeing, but hearing your patients, just like Dr. Nguyen said. So I would love to hear from you, Dr. Trung. Was there anything that Dr. Nguyen said that stood out to you or reminded you of your training or the things that you do in your day-to-day?
Yeah, absolutely. Thank you. Thank you for having me. I'm like really, honored to be here. Yeah, what really resonated with me was with Dr. Nguyen, how he started with like just kind of marveling at all the medical advancements that we've made in treating cancers or just like any variety of pathologies. But then on the kind of other side, the growing disparity that people often our patients suffer from, maybe like people of color, people more with like lesser socioeconomic means. And then questioning why is that, right? Um, and then when you uncover it, there is like the illusion of like equal access, and then how does that affect us personally? So there's kind of like two parts to that, and what I've kind of learned is that there's like the individual where me, the provider, as well as then with the patient, we're both struggling to how to navigate the system. How do we increase their options or the adequacy of their care? And the struggle with that and realizing it's like a larger structure, right? Like it's a continual issue. And then what can I do because of that? I think it's easy to fall into nihilism. It's easy to kind of lose hope and to kind of accept the system. But I think on the other end, the more radical approach or the more loving approach is then to like, find people in your community and to like build connections and relationships on how and then to question like, can we create a better system? What is one that doesn't prioritize money or just like efficiency of like financial care versus a system like really built on, and not to sound cheesy, but like really to build on love, right? Like what do we believe is the most important thing, and is that's the sanctity of life, and that's something I believe in. Um, but then how does that manifest in like material systems and institutions? Um, so yeah, obviously we're far from that. We have a long way to go as a country, as a like world. Um, but that the hope, that idea, those dreams still need to be continually remodeled and strive for, because at the end of the day, people suffer from it. Millions of people suffer from it, and but yeah, I think that I really like what Dr. Nguyen said about like not to lose hope, because at the end of the day, that's all we have. Okay, thank you.
Thank you. Thank you. And Miss Rivera Sanchez, when Dr. Nguyen talked about clinical trials and conversations that he's had with people who feel like, oh, I don't want them experimenting on me. You are the founder of Trials of Color, where you speak exactly to that, bridging that gap between the community and researchers to be more inclusive and understanding, but also to be educated, and you advocate around clinical trials trials. So what was it that Dr. Wynn shared? It probably was that statement, right? We probably connected with the same thing because I immediately thought of you.
Yeah.
But was there anything else that you would like to echo and amplify that Dr. Wynn mentioned?
The main thing that Dr. Wynn mentioned was we just don't ask the question. And if we do ask, just like he said, you sound crazy. You have to, in order to make a decision, you have to understand. You have to understand where we come from and where we are today. So clinical trials are totally different today than many years ago. When I talk about clinical trials, I always get, especially if I'm in, depend on where I'm at, but I either hear words like guinea pig, Henrietta Lacks, Tuskegee. I answer all of those. I was in two clinical trials, and I don't feel that I'm a guinea pig at all. And normally in a cancer trial, it's not like long time ago, like this sugar pill. When we talk about Henrietta Lacks, that took place. That took place in 1951 when we had zero laws, no laws in place. We did not have people that looked like you and I sitting at NCI for, representing patients and, on different boards. So what he really mentioned is just have the conversation and ask the question. We will participate if you ask the question. So the main thing that I can definitely relate is just ask the question. I can go on and on. I do want to throw out Tylenol. I always use the example of, and this really tell my age, but when you had a child and the child had diarrhea, you needed a prescription for Pedialyte. Now that's over the counter. And that's because someone participated in a clinical trial to change things. So if we looking at finding a cure and what drugs work better, it's going to be through the clinical trial. So yeah, I better hush because I'll take over the thing. So yeah.
Yes. And everything that you said, I'm happy that Dr. Wynn mentioned that because it moves so seamlessly. And the other thing that stood out about what Dr. Wynn said is he talked about the importance of having a choice, right? And even having access to choices. And that's what this whole event is about in our workshops. It's centered and focused on shared decision making and the people that we've met along the way. And one of those people are Miss Tamron Collins, who is a nurse and running your own practice in the Mississippi Delta, which is a place that doesn't have Medicaid expansion, so when we talk about shared decision making, I know that you're big on empowering your patients to really co-create their healthcare journey with you. So can you point out or remember one example or experience of a patient that you were able to empower when it comes to shared decision making? Oh, wait, you're unmuted. I meant you're still muted.
Okay, is that better?
Yes.
Yes, I actually can. I can actually remember a patient about 2 days ago, and sometimes the decision that they make is not the one that we always want them to make either. But we have to be aware that this is their life, this is their body, and sometimes they may make a decision against treatment. And we know that treatment is out there. But I had a patient 2 days ago that has a serious health problem where he has a cancer, and he has decided no radiation, no chemo, even though there are methods out there to be able to try to fight against the cancer. He's decided, no, I don't want that. And when he went to his appointment, which is like 2 hours away from us, his biggest problem was he had to travel. He has to travel 2 hours away to get the health care that he needs. So number one was, I don't want to ride the bus. Number two was, I'm over 80 years old. The medications may make me feel bad. They may make make me feel weak. And I don't want to feel like that. I want to spend the remaining of my life at my strongest. And so it's not a decision that I was so happy to hear. Neither was the oncologist, but I had to empower him and let him know, this is your body. You have the right. And if this is a decision that you want to make, I support you and I will help you facilitate that decision and let the oncologist know this is what you choose for your life. And he just thanked me and told me that it felt so good to have someone to actually understand, because at his appointment with the oncologist, they were not hearing the refusal of him wanting to use the methods that are available now to treat his cancer.
Yes. And sometimes that's hard, just like you said.
Very yes.
You with your medical background, your knowledge, you have this one perspective and viewpoint of potential outcomes of what can happen. But at the same time, like you said, I wrote it down, it's their life, it's their body, and
Yes.
it's their choice. So it's our as in providers and supporters and patients and advocates to hold hands along that, because pushing back only makes that decision harder, right?
Yeah.
And the person feel guilty, and we want to relieve that. So George, do you have any stories? I feel like you would be able to relate to Tamron as well, of moments like that.
Yeah, actually, incidentally, I'm on palliative right now, and it's like very very sick people, and we have like often like, a lot of like very tough discussions on how do we move forward, and I think obviously there's like we have a lot of models on like patient and patient doctor interactions, or there's like the active passive model, there's mutual cooperation, and that's one that often we try to opt for. Um, and what does that mean? It means that we try to create a more like egalitarian relationship where both people have the same amount of respect. We
Yeah.
both came with our own knowledge. My knowledge being like the medical right know-how, but then their knowledge of like what is comfortable for them and exactly what Miss Collins said, they know they have an idea of what they want their life to look like, right? And um, then we had discussion, what does that look like for you in the next 5 years, 6 months, or even 2 weeks? What does that mean to you? And including your family. It can be really hard seeing people face hardship. Often people live very quite wretched lives, and often not because of their own faults. Um, but then at like we try to work on it where we create some space of them having some type of like control over their lives, some type of like form of like advocacy. Um, and I think that's the most important is where at the end of the day, we often feel like we don't have much choice, especially when we're diagnosed with end stage cancer or whatever
Yeah.
not. Um, and then, so then how in some way do we empower them? At least they may go out on their own terms, or at least they may not constantly feel like they're being ripped apart. Yeah, I think that's, hopefully that answers your question.
Yes, that was perfect. I love that terminology, mutual cooperation, and Sharon, I feel like you basically kind of touched on that when you talked about people's different viewpoints around clinical trials. And so you, as a woman of color, speaking to other people of color about clinical trials and respecting their wishes, but also being on that verge of, let me educate you, let me help you. What has that experience been like for you? Do you have one experience or example that comes top of mind for you as well that can speak to that?
Sure. I have several, but one, the main thing is that you have to take the time to answer the questions and educate, because there's so many myths out here, and that may take quite a long time. I had one person that I met doing, we was giving out blankets during the infusion while she was having infusion. And I actually worked on her for 1 year. She would come back and have more questions. And once she made up her mind to get in this particular trial, she actually, they had closed that trial, so she couldn't get in it. So it took 1 year. So I don't give up, and I do respect the opinion, but I want to know the reason why. And again, what my three is, the guinea pig can relax and Tuskegee. So I normally, what I do is address that up front. I don't try to let someone else bring it in. I address that up front, and then I'm open to questions, because it's just like myself. I didn't know a lot. I mean, I hated science, the only thing. So me and Dr. Wayne got something different on that. He loves science, and he said he don't want to be wrong. I hated science. The only thing I knew about science was dissecting the frog, and it's like, ew. So I hated science. So I had to learn about science. So I will say it's a beautiful thing. I am not at his level of learning, but as you learn as an advocate and as a research advocate, you take that information and you bring it to your community. And it's not always online. I mean, just last night I was down in Petersburg, a very nice community that I was down there talking, and each chance that I get, I'm going to talk about it. I was down there for another reason, but I had my banner and everything, and I started running my mouth about it. It's a subject that dear to my heart. And, when a lot of times people say no, I'm like, well, if you get a cold, do you take Tylenol, Benadryl, all that stuff? All those medication had to go through a clinical trial. And speaking of African American, for the last 16 years, our numbers have been 4.5 or 5% that has participated in a clinical trial. I do not want to see anyone join the cancer club, but unfortunate, when we look at our numbers, 1 in every 8 women get breast cancer at least. So in order to make a difference, to see if this drug work on us, we need to participate so we can be around 8 years later talking about a clinical trial. We all know triple negative. I mean, I thought triple negative is negative. That's a good thing. I was told no, it wasn't good. Again, I didn't know about science, so I'm thinking negative is good. So in order for us to continue to be around, is no guarantee with a clinical trial. So I don't want to give that, oh yeah, everybody get in a clinical trial. That is no guarantee. But new medication, if you are in a medical clinical trial, and I don't know if you want me to keep talking because I'll talk forever.
Well, no, but thank you for that perspective, because not everyone understands the importance behind it. So I love what you said, asking a person, well, why do you feel this way? Why are you hesitant about something? And then using that as a conversation starter, right? To just share your perspective and the history that you know. And like you said, the benefits on the other side is that now these clinical trials, when they are more diverse, their results are more diverse. Now they can tell with their results who this truly will help. But if your clinical trial is only one group of people and it says that it's 100% effective, but you weren't a part of that, then that impacts those results. So I love what your perspective of really understanding where a person is and helping them. My mentor has this line of finding common ground before taking a person to higher ground, and so that's what I'm hearing you say. Yes,
yeah,
and yeah, you're welcome. You can use that as your own. And one other thing that I think it's very important, you mentioned inequities and the different inequities and numbers of African American women being diagnosed with cancers and everything, and that is the reality of it. And so when we titled this event, Do I Have a Choice? The importance behind that was to realize that before we can even talk about shared decision making, we have to first have access to those choices. And I remember at our California workshop, we had a woman who shared that her oncologist didn't ask her or educate her about the Oncotype DX test, because he said, well, I just thought that you couldn't afford it, so I didn't bring it up.
Right.
So therefore, she didn't have a choice, right? Because she didn't
Right.
even know that there were options.
Right.
So when we think about inequities, and George, I know you being a student and you are in the thick of it, of understanding the system and how sometimes it can be overwhelming and broken and people need help. What are some things that you do personally in your practice to help people navigate the system and find resources and answers?
Basically, what we do is give them the tough questions to ask. No question is a dumb question. Ask the question, meet with them wherever they are. Now, you'll hear that term used loosely. And I don't mean behind the desk in a white coat or on the internet. It may be you have to go to that particular neighborhood to actually meet and explain. So a lot of times we are here, just like this young lady, the young man said that it's transportation. You know, I don't want to travel 2 hours. So if transportation is a problem, we see what can we do to bridge that gap. Speaking of Dr. Wynn, our organization received a community seed grant from Massey Comprehensive Center. And you know, we had people that said, I can't get there because I need gas. Well, a small gas card could knock that barrier out to try to include us. But, you know, I'll go back to ask the question, the gas card, educate, advocate. So we also teach them, what do that look like to advocate for yourself? For me, it looks like the 3 or 4-year-old that won't accept no for an answer. You keep asking the question until you have the answer. One of my physicians, I love him to death, he wrote in my chart, she's back again today. I spent 1 hour with her and her friend answering questions. Yes, until I understood it. So that is some of the things we do. I'm always open to having a conversation. And I mentioned last night in Petersburg, the governor gave a re-entry program. Okay, what did that have to do with cancer? Well, don't worry, I made it work. It had a lot to do with it because I was down there answering questions. And that's in a city that is underserved. So we have to take the programs where the people are, and we actually have to bridge the gap and answer the question, ask the question, and see what can we do to solve the problem. Transportation, to me, is one of the easiest problems to solve. Asking a question, it's a very easy to solve. We tell the patient, don't be intimidated. I try to use that, hey, my doctor say I'm back again. I'm like, yeah, act like the 3-year-old. Mom said, no, I go ask that. You just keep asking until you understand it, and tell them, break it down like I'm in first grade. I did not go to medical school. I don't understand what that negative means. I think that's a good thing. So those are some of the things that we do. We also listen. We do listen, and we listen when everyone is closed and they just need someone to talk to. I don't mind, you know, I got a call the other night. It was someone that know me, and a family member was diagnosed, and she said, are you sleeping? I'm like, I'm not really. I'm looking to see I was asleep. And she told me to start. I'm like, oh, it's no problem whatsoever. I'll pep right up, because I remember the feeling that I had. I mean, we go through, a lot of people won't admit it. It took me years to admit it, but we go through grieving when we are given that diagnosed, you have cancer. Long time ago, cancer equaled death. We heard Dr. Wynn said that's not the case now. It can be, so I don't want to give nobody no, but it's not the case now. So I remember the feeling. I remember like I was in denial. If someone said, you know, were you in denial or are you scared? I ain't scared or not. I was terrified. So I
Yeah, but we,
know,
like you said, we've come a long way with
right.
those advancements, and I love the mindset of meeting people where they are. And George, with you in California, what's something personally that you've done to help with those inequities?
It's, it's, of course,
Oh wait,
um,
your audio's breaking out a little bit.
hear me.
Yes, keep going.
Okay. The work system. I guess one issue is, usually
Sorry, George. Yeah, maybe taking your AirPods out. It'll be better.
that.
Technology sometimes doesn't work in our favor. And then switch the audio and then just do it through your computer, the old school way. No, we can't hear you now at all. We'll give you a second to reconnect. But even with that, I think what Sharon says connects with you, Tamron, because I remember when we were in Mississippi at the workshop, Tamron, you talked a lot about the relationships that you build with your patients, right? And I feel like you truly make it feel like a home to them, you know, and like a safe place. And I don't think if when everyone thinks about their healthcare providers, if they think that they feel at home and safe. And so for you, you know, what are some key ingredients that you use in your practice to make people feel safe and listened to?
Well, first, I always, whatever the condition is, the disease process, I always let them know options. We have options. Options are always available. Then after the options, I want them to go over the options and know that you have 1, 2, and 3. How do you feel about A, B, and C? I try to cater it to which one would be more feasible for them to understand, them to get through the process with whatever option that they feel is best for them. Just knowing that they are in charge is more important to me than anything. That they're in charge of whatever decision, healthcare decision that even if it's a disease process that they do not understand. Just know that we will talk to you, like Sharon mentioned, we will go over it with you over and over again until you understand and that you are able to be highly involved in the decision because it's your body.
Yes, I love that. I love that. And that speaks to our title, Do I Have a Choice? You know, and really empowering people to realize the decisions that are available. And George, I think that we have you back.
Yeah, absolutely. Oh, should I go answer the prior question?
Yes, yes.
Yeah.
Question about what you do personally in your practice to help people
Yeah.
navigate the healthcare system.
Yeah. So I mean, it's I guess being in LA County has its own issues and difficulties. Um, but one of it is just it's like very overwhelming. Like the system is just overflooded with patients that are very, very sick. And oftentimes they have other issues going on at home, like not making appointments to the work, transportation. And so I think one way is just like identifying barriers, similar to what Ms. Rivera said. Just figuring like, oh, why are they missing their appointments? What can I do to help? But then also just like kind of talking with them or just like being very real about expectations. Like, look, like this is unfortunately it's a very overwhelmed system. And it's not to like say we are giving up, but it's gonna be a fight. And then if you can just be patient with me, I'll do my best to try to get you the follow-up care that you need and like to discuss the options that you have. Um, as long as you can just try to hang in there with me. And I think it's like it becomes like much more of a partnership. And what we can do that. And sometimes that maybe we do extra calls, maybe we do extra visits, but we'll make sure you get to the point where you need to, so then you can have more choice, an actual choice. Yeah.
I love that. You and your generation of doctors are truly dismantling this previous thought process of a power hierarchy, right? And a patient-provider relationships. And you all are really turning it on its head. And so for you, George, do you feel like you attribute all that you're doing and this understanding and the relationships that you build with your patients, is that attributed to your training in school, or is it based on your own personal experiences or things that have happened to you or loved ones? You know, what has really shaped you into the physician that you are today?
Yeah, I think to some extent, I think there is a movement within just like medical education to be more, I guess, humanistic. But I think at the same time, I think more, I guess, like just like I'm gonna steal from Cornell West, but I guess I am who I am because someone loved me. And I mean that in the way of like I've had so many people in my community help me and like teach me, especially when I was wrong or even when I was like hurtful. They kind of create a room for, I guess, like what we call like restorative justice, where I would have to learn to like meet other people and understand my harm. And I think we're slowly recognizing that in medicine, that like this hierarchy, especially in the historical situation of just like white supremacy, racial capitalism, just all this history of like exploitation. Um, we like to continue to have like that kind of disparity and power just only like prolongs that exploitation or that harm. And so, yeah, so I guess like how do we create spaces that needs to become a partnership, and then has to start with humility, I think. Yeah.
George, you just spoke to my whole heart, and I feel like the whole hearts of all of the audience members. And this is exactly why we wanted to highlight you, you know, because we got a glimpse of that in California. And I love what you said, the humanistic approach and really breaking down all of these injustices and realizing that it has to happen in every area of life, right? It's not just in social justice, but social justice also includes medicine and our bodies and our lives. And Tamron, as a nurse practitioner in an area where hospitals are closing down, or sometimes you know, people have to leave the town, or people have to travel hours to even get care. Can you share about the importance of your role, you know, and the roles of nurse practitioners in your area?
Oh, yes. It's the nurse practitioner role in the Mississippi Delta is it's much needed. Patients, a lot of them when they come to me, they say, "Oh, you sit down, you actually listen to me, you take time with me. My concerns about my healthcare really matter to you." So our role is very pivotal in the community, that we're out here letting the patients know that we are here for you. We are advocating for you, because that's a part of nursing in itself, just being a patient advocate. So, yes, the role is very important in the Mississippi Delta, because the patients, doctors are hours away sometimes. Like I mentioned before, that the patient had to travel. He's not concerned about the financial aspect, because I've made the resources available, whereas he does not have to pay anything to travel. It's the ride. He doesn't want to ride 2 hours to the appointment. It's about that. So then we sit and we talk about, I never give up on my patients. I always say at each visit, we go over it again, and I try to encourage them. Hey, they have this resource out. They have this new treatment out. And so it's the time that you spend with the patient to help them with maneuver and navigate through their disease processes. Yes.
Yeah. I love that. Truly seeing people, you know, and respecting them and hearing them and making them feel valued. Exactly what George said. Having someone love you, you know, and being able to feel valued, you know, feel like your perspective and your preferences are valued. Because a 2 hour ride, is that 2 hour ride just one way?
No, it's going and coming. So it's 4 hours.
Wow.
Yes.
Okay.
Back sometimes at midnight. Sometimes it's yes, because if the appointment is at 3, we try to get the appointment scheduled early in the morning, but you know, sometimes that's not possible. So some appointments are scheduled 3, 4 p.m. in the evening. Then they have to sit at the appointment, then wait, then ride back 2.5 hours sometimes. And I understand. So he said, "I'm glad that you don't make me feel stupid," because the doctor looked at me as if I were stupid. I'm not stupid. And I said, no, absolutely not. I understand how you feel. I understand your heart. And I understand that this is the decision that you want to make, and I respect it. However, there's still other options. I still make it available to him. So that's important to be able to discuss that. And at his next appointment, we'll go over it again. You never give up. You always, always let them know there are options and that you have the right to decide which option you want to take.
Yes. I love that because time is valuable. You
Yes.
know, a 4-hour round trip that is valuable. And like you said, even the weakness that he might feel in the body and the fact that he's 80 years old, there's so many layers in that situation that makes it even more difficult. And so for all of us, as we wrap up the panel, because all of you are such amazing change makers and pillars in your community, if you had a magic wand and you can use that to advance healthcare and the journey and the decisions and the access and quality that people have, what would that look like? Like, what would your one thing that you would like to fix and perfect tomorrow, what would that be? And I want you all to share that because there might be audience members who want to reach out to you and say, hey, I actually have resources for that or connections, and this video will be shared widely. And we want to make sure that all of our policy consortia, the goal of it is for the next step to be for people to take action, so as people are listening in, what are those take actions that you would like them to share? And I'll start with you, Sharon, and this will be a quick fire round.
Okay. I talk a lot. Okay. For survivors and patients, I would say get involved in research. I hated science. Science is nice. So get involved in research. I'm more than happy to answer any question I can in reference to clinical trials. There's so many benefits as well. However, for physicians, ask the tough questions, have the conversation, partner with some of your advocate group. Do not judge us by our skin color or our zip code. We may have other resource that we do not choose to share with you. So you still have the conversation. But main thing, don't look at us and say the zip code is here. No, don't ask them. So that's what I would say. And hopefully that was quick enough.
Yes, that was perfect. Tamron?
I tried to think of this. I feel like the healthcare industry is lacking compassion. I wish more people would have more compassion for others in consideration of everything. Like before you make a medical decision, consider the entire patient. That's why it's so important to me that I meet my patients and I learn everything about them, because you have to be compassionate and considerate about each treatment choice that you decide. So,
George?
Yeah, I think a little more broad, but I think not to feel like you're isolated or to like fall to fear, but I think find communities that you can help organize with. I think that's like the most important thing. Yeah, people you can organize and form and feel like where you can act out of love and hope. Yeah.
I love that. Well, thank you all three of you. Thank you for being here with me, for sharing this space. It was an honor to meet you in person throughout this year at our workshop. It's an honor to have shared this with you today and for you all to meet each other. And I'm just excited because you all signify the future, the future of our leaders in healthcare. And just like Dr. Wynn said, the future is here, but just unequally. But now we have people like you who are doing the work every day to make sure that we do achieve that equality. So thank you for all that you do, and thank you for being here. And now we will have a little video slideshow that shows you more faces that we met along the way at the different workshops.
We went to Ruleville, Mississippi, Richmond, Virginia, and Los Angeles, California, to learn more about the decisions that patients and caregivers who are living with cancer and other chronic diseases make during their long illness journeys. We wanted to understand what shared decision-making means to these individuals and their communities, what barriers exist to good communication and trust with healthcare providers, and what obstacles stand between patients and access to the remarkable advances being made today in cancer treatment and care. These are some of the people we met on our journey.